let's get started. My name is Alan Hudson from the Immuno-Oncology Translational Network Data Management Resource Center. I also serve as Chair of Biostatistics and Bioinformatics at Roswell Park Comprehensive Cancer Center. Before we start the seminar, I just have a few bookkeeping items to review. Questions will be responded to at the end of the joint presentation. Please enter your questions in the Zoom Q&A box. The audience can prioritize the order of the questions by clicking on the thumbs up button. Closed captioning is available. The closed captioning for today's webinar can be accessed by clicking the live transcript option in the Zoom menu at the bottom of your screen. Instructions are also provided in the chat box. The recording of today's webinar will be available a few weeks after today's presentation, hopefully if the government doesn't shut down here. With that, I would like to introduce our moderator and co-presenter, Dr. Michael Fiore, who is Emeritus Professor at the University of Wisconsin School of Medicine. University of Wisconsin of Medicine, sorry. Dr. Fiore founded and has served as director of the University of Wisconsin Center for Tobacco Research and Intervention since it was established in 1992. Dr. Fiore served as chair of the panels that produced the United States Public Health Services Clinical Practice Guidelines treating tobacco use and dependence in 96, 2000, and 2008. Dr. Fiore also chaired the U.S. Department of Health and Human Services Subcommittee on Tobacco Cessation of Interagency Committee on Smoking Health that produced a comprehensive plan for promoting tobacco cessation in the United States. In 2005, Dr. Fiore was asked by the United States Justice Department as part of their landmark lawsuit against the tobacco industry to craft a $130 billion 25-year plan to assist 33 million smokers to quit. Dr. Fiore has served as principal investigator on 5 consecutive NIH Center grants and was an inaugural recipient of the NCI R35 Outstanding Investigator Award in 2015, which is subsequently renewed. He served as senior scientist on the NCI Moonshots Initiative, the Cancer Center Cessation Initiative, C3I. He is a recipient of numerous awards and honors, and in 2012 he was elected to the National Academy of Medicine. That's a lot to go through as an intro. Thank you, Dr. Fiore.
Thank you, Dr. Hudson, and thank you all for joining us today as we talk about the Cancer Center Cessation Initiative, also referred to as C3I, a program designed as part of Moonshot to help all cancer patients in America who smoke to successfully quit. I'll be giving some context and overview. Dr. Betsy Rowland, the principal investigator on the initiative, will then be describing the coordinating center and how it was essential to the success in organization of the initiative. And then finally, Dr. Jessica Burris will describe her experience as director of the C3I program at the Markey Cancer Center at the University of Kentucky. Next slide. So first, some context. Moonshot has set as a new goal through President Biden that we will cut cancer rates in half over the next 25 years. Essential to achieving a goal like that is to help people quit smoking, since about 30% of all cancer deaths in America are directly caused by smoking. And we commend the president and the Moonshot Initiative for highlighting cessation and making it part of Moonshot. What is less known is that many newly diagnosed cancer patients smoke about twice the rate of smoking as the general population. And we know that if you're a cancer patient who smokes, your outcomes are compromised by smoking. And if you quit upon a cancer diagnosis, you can increase the effectiveness of your cancer treatment, you can decrease side effects of cancer treatment, and all-cause and cancer mortality declines. Thus, smoking cessation is essential when a patient gets a cancer diagnosis, preferably early, but if not, then. But prior to the inauguration of C3I, no program existed to ensure that cancer patients in NCI-designated cancer centers routinely receive smoking cessation treatment. Slide. Thus, in response, NCI in the Division of Cancer Control and Population Sciences announced the Cancer Center Cessation Initiative in 2017, part of the first moonshot. Ultimately, 52 cancer centers of the approximately 65 were funded over 3 rounds via P30 supplements, and their goal was to advance the capacity of these cancer centers to treat the tobacco use of all oncology patients who smoke. It wasn't prescriptive in saying how to do that, but rather it said take a population-based approach. That is, identify and treat every cancer patient who smokes and check the outcomes, make sure that they get smoking cessation treatment and see if they successfully quit. The coordinating center was set up at the University of Wisconsin. Next slide. Back one, please. So I want to just go over some of the outcomes of C3I. Slide. So first, over 97,000 oncology patients in NCI designated cancer centers have received treatment as part of C3I since it was launched in 2017. And you could see the 6-month accrual rates were now above 97,000. Next slide. These, of course, are 97,000 patients who would not have received cessation treatment without this. But we also looked at whether they quit. And smoking is an incredibly addictive behavior, and it's particularly difficult for cancer patients who quit, given what they're handling. The United States Preventive Services Task Force has set a level of at least 15% quit rates at 6 months for programs. C3I exceeded that by about 50%, well over 20% in both of the time frames that I share with you now. But what about equity? Did we reach all patients? Next slide. So if you look at the blue on the left, among all cancer patients who smoked, the C3I programs reached about 17% of them, but we overreached women and we overreached older Americans who are often ignored by cancer cessation programs. Next slide. When we look at race and ethnicity, we overreached Blacks. Over 20% of them participated, and we also overreached Hispanic patients. Next slide. And finally, we know today in America that smoking is particularly concentrated in the poor, and we particularly overreached individuals who had Medicaid or got their health care from the Indian Health Service. We also overreached Medicare, older patients who have high rates of cancer. So in this initiative, we were able to work with 52 cancer centers across America. We were able to implement programs. Each of these centers implemented their own programs. We reached almost 100,000 oncology patients who smoked, and we reached the underserved populations in particular. But most smokers don't get their cancer care in NCI designated cancer centers. They get it in community cancer centers. So what about them? And happy to report that in part as a result of C3I, a collaboration was established to reach out to community cancer centers. Next slide. The Commission on Cancer, and I want to just describe that for you a bit, established a program called Just Ask. The Commission on Cancer represents 1,500 cancer clinical treatment centers across the U.S. who treat 80% of all cancer cases in the U.S. In 2022, under the direction of Dr. Tim Mullett, a thoracic surgeon at the University of Kentucky, the COC developed the Just Ask program to increase the rate of identifying smokers at COC sites, these 1,500 sites. And then they expanded in 2023 to then try to help those smokers to quit. a program referred to as Beyond Ask. Next slide. So a little bit about the Commission on Cancer. It's a consortium of these 1,500 cancer centers. It establishes common standards to ensure the quality and comprehensiveness of cancer care. It conducts surveys to assess clinical cancer center compliance with these standards. It then gives feedback on performance and educates these centers. So a performance standard by the Commission on Cancer can have great impact on what happens to a cancer patient in sites across America. Next slide. What about the Just Ask, the first initiative? It was an elective quality improvement project, which is the way new standards are established. It charged the clinical sites to leverage existing resources, and it's basically said that all cancer patients should be asked about their smoking status and have it documented and integrate that into the standard of care. So what were the outcomes of Just Ask? Next slide. 776 of the 1,500 oncology clinics enrolled in this quality improvement initiative. We had baseline data, and then 6 months later, because of the nature, the program has the potential to reach over 700,000 cancer patients. So what were the outcomes? You see the baseline in red on the right and the 6 month later data on the blue. The sites were actually doing a really good job of identifying their smokers, about 85%, but increased to about 97% after the initiative. And even though the Just Ask initiative didn't ask them to implement smoking cessation treatments, virtually all of them increased. Advice to quit, assisting them in quitting, providing counseling, and even prescription of FDA-approved medications. All of these increased as a result of the initiative. And the first part of this quality assessment instrument was shown to be highly effective across these over 700 clinical sites. Next slide. So they then moved in 2023 to a second program called Beyond Ask. And here the goal was to increase the number of patients offered assistance for smoking cessation to enhance their capacity to deliver it in COC sites. And the goal ultimately is to increase the proportion who receive the treatment and those who ultimately quit. So C3I showed that we could change fundamentally what happens in NCI designated cancer centers, then as an outcrop of C3I, but as a result of an organic initiative from COC, it now is getting into community cancer sites across America. And it shows that we could change the standard of care and ensure that every cancer patient who smokes is offered assistance and receives it so that they do better with their cancer treatment, have fewer side effects, and all-cause mortality as well as cancer mortality decreases. Next slide. So with that, I'm going to turn it over to Dr. Betsy Rowland to talk about the coordinating center.
Thank you, Dr. Fiore, for that overview of the impact that C3I had on patients across the country. Now, I'd like to share with you the role that the Coordinating Center played in facilitating some interesting scientific and organizational impacts in C3I. So my name is Betsy Rowland, and I recently joined Sage BioNetworks as the Associate Director for Team Science. Previously, I served as the Director of Team Science for UW-Madison's Carbone Cancer Center and Institute for Clinical and Translational Research. And my research focuses on coordination and collaboration in team science projects, including how to design, build, and evaluate infrastructure to support complex multi-investigator initiatives. And I served as the PI of the C3I Coordinating Center from its inception in 2017 until leaving UW this summer. So as Dr. Fiore mentioned, a total of 52 NCI-designated cancer centers out of the then 64 clinical and comprehensive cancer centers received funding over 3 cohorts. As you can see, the sites were nicely geographically distributed, allowing the initiative to reach key populations across the US. Initially conceptualized as a one-time administrative supplement for a modest number of centers, C3I launched with 22 centers participating starting in September 2017. Knowing the importance of initial face-to-face meetings for launching consortia, we quickly organized a meeting of all funded sites, where we heard from each leadership team about their plans for developing and implementing their TTP. The diversity of plans was amazing and helped us as the coordinating center to quickly see that the support and facilitation that we offered needed to be equally diverse. NCI also quickly realized the potential that C3I had to impact clinical care and organized a second funding opportunity, funding an additional 20 sites in year 2 of the initiative. In year 4, cohort 3 with 10 sites joined the initiative, and 11 of the cohort 1 and 2 sites received enhancement funds. The competitive enhancement program provided those sites with additional funds to expand a specific aspect of their program or to conduct a pilot study of a potentially innovative idea. As I mentioned, the Coordinating Center itself began our work in July 2017 before the sites were funded, following the best practice of launching the Coordinating Center in advance of the funded sites to ensure that systems and processes are in place and ready to support the funded sites. The Coordinating Center team consisted of myself, along with Dr. Fiore, who served as our senior scientist and expert in tobacco treatment programs. Dr. Danielle McCarthy recently took over as the PI of the Coordinating Center when I left UW. Rob Atzett served as our outreach liaison with a focus on the use of EHRs to support TTPs. Dr. Tim Baker served as a scientific advisor, while Drs. Jennifer Bird and Heather D'Angelo have served in the role of project scientist. Mara Minion is the current C3I project manager, and Danielle Pock served as our program manager. The Coordinating Center developed 4 guiding principles for our work on C3I, drawing from the literature on the science of coordinating centers, the science of team science, organizational psychology, and implementation science, as well as our own previous work building, leading, managing, and evaluating similar large coordinated collaborative research initiatives. These 4 guiding principles included work to build community through the facilitation of a culture of openness, inclusivity, and trust, invest in resources for systematic, continuous collaborative learning across the network, collect data, check in, and report progress to participating centers, and identify and provide tools and resources to meet grantee needs. These principles guided our work as the Coordinating Center, including the activities that we implemented, the evaluation data we collected, and the way that we interacted with the centers. First and foremost, we always kept in mind that the goal of the Coordinating Center was to be in service to grantees, to provide the centers with the infrastructure, meaning the tools, people, and resources that they needed to accomplish their work. The success of a coordinating center is inextricably bound to the success of the initiative. As such, we really tried to integrate a number of data collection efforts into our work in the Coordinating Center. As you saw earlier, we collected data on program characteristics and reach and effectiveness from each funded site every 6 months. We also conducted virtual site visits with each site a few months into their funding cycle. These virtual site visits had 2 purposes. First, we wanted to understand each site's unique challenges to ensure that the services and tools that we were providing were helpful and to identify any new needs. Second, we wanted to offer them advice on their approach, leveraging the substantial expertise and experience of Dr. Fiore's team at CTRI. And it's important to note here that many C3I program leaders were new to tobacco cessation and to TTP development, and grantees have shared that this guidance was invaluable to them. Third, Dr. D'Angelo, then our project scientist, and I conducted in-person site visits with cohort 1 and 2 sites, a practice that was unfortunately halted due to COVID. Those site visits allowed us to delve more deeply into each site's implementation, collecting incredibly valuable qualitative data about each program that has been used in several publications and were really helpful for us in shaping our program offerings as the Coordinating Center. Finally, at the end of each site's funding, we conducted an exit interview where we asked the teams about the lessons they had learned as part of C3I and how they were planning to continue their programs. Our first principle, our North Star of sorts, was building community, because without that community and a culture of openness, inclusivity, and trust, we knew that the initiative would not be able to achieve its scientific and organizational goals. So we devised a number of activities specifically designed to develop that scientific community. First, we organized twice annual meetings where we heard from all programs about their activities and progress. Because of the large number of talks in a relatively short time, each program was limited to 5 minutes, which is very short, and we prescribed the format, including a request for them to share one big win and one big failure, something they had tried that hadn't worked. And we did this for 2 reasons. First, we wanted to create an environment of innovation, and the only way to innovate is to try new things. And when we try new things, sometimes we fail, and it was important to normalize that failure. Second, the sharing of and celebrating failures removes the pressure of trying to impress others, again, creating that culture of openness and trust. Second, we encourage programs to share materials with one another, things like recruitment flyers and educational materials for providers. Again, this sharing and learning from one another was critical to developing a culture of trust. Third, we held frequent webinars on topics of interest for the grantees, often delivered by their peers on topics such as getting buy-in from the Cancer Center and health system leadership. We also delivered webinars on aspects of health equity, including inequities in delivery of care to LGBTQ+ populations, racial and ethnic minorities, and immigrant populations, featuring C3I members or external experts.
External.
Oh, somebody needs to mute there. We noticed a number of outcomes from these activities. First, program leaders quickly moved from the competition mindset that's inherent in securing funding to a cooperation mindset that we were all part of one initiative and we succeed or fail together. They developed new or enhanced existing cross-network relationships. And finally, one of the outcomes that we are most proud of and excited about was we began to notice increased participation by frontline staff like the tobacco treatment specialists and early career researchers. This shift from the lead PIs presenting on behalf of their programs to other team members being spotlighted, who tended to be earlier in their careers, people of color, and women, meant that we were hearing very different perspectives on program development. The overarching impact then from this focus on building community was a shared learning, which we'll talk about in the next slide, and faster program implementation in cohorts 2 and 3. The feeling of community and commitment to the initiative also led to sustained participation in C3I and our working groups, even after sites funding ended. And as I mentioned, increased diversity of viewpoints from tobacco treatment specialists and project managers with our focus on health equity issues. Our second guiding principle was to invest in resources for systematic, continuous collaborative learning across the network. C3I was funded because the work of developing and implementing tobacco treatment in clinical care for cancer patients was not being done regularly across the cancer centers, meaning that how to do this work, especially in specific contexts, was not necessarily a settled question or super clear to our grantees, especially with such a short funding cycle. So we needed to be supporting rapid learning across the community. It was also imperative for us, as I mentioned on the previous slide, that cohort 2 and 3 sites were able to take advantage of the lessons learned by cohort 1 and to implement and succeed even more quickly. The stakes for patients and their families in this work are incredibly high, and we saw it as part of our mission to make the work being done by C3I sites as efficient and effective as possible. So as we prepared to receive cohort 2 sites, we developed a mentorship program where we matched each incoming cohort 2 site with a cohort 1 mentor. And we did our best to match sites geographically with the hope in pre-COVID times that they might be able to actually visit one another's programs. And in fact, we did learn in our exit interviews that many of the mentor-mentee pairings did this. Second, we organized Jumpstart webinars for cohort 2 and then cohort 3, featuring previously funded sites talking about the stages of implementation, such as securing buy-in, launching, etc. The virtual site visits and all grantee meetings I mentioned earlier were also key to generating network-wide learning. Some of the outcomes we saw included increasingly deep and close connections among sites who were able to connect over shared challenges, connections that were often facilitated by the coordinating center, and a list of experts that we developed who volunteered to assist new sites and even those cancer centers not funded under the initiative. These mechanisms and communication tools enabled ongoing communication among sites and between sites and external experts around the best practices that were emerging from our work. Again, I want to highlight the impact of these activities, including faster implementation in cohorts 2 and 3, as well as a library of resources available beyond C3I, contributing to and improving the entire field of tobacco cessation. Many of these best practices and the library of resources have been made available in other contexts, including the Commission on Cancer work that Dr. Fiore mentioned earlier. In a high-profile initiative such as the Cancer Moonshot, showing value is absolutely critical to its success. As such, we honed in on what it would mean for C3I to be successful, which included overall reach and effectiveness of the funded sites, as well as that community development. To measure our progress on these fronts, we took a continuous improvement approach focused on frequent data collection and assessment of alignment between our results and our desired outcomes. Importantly, we made sure to only ask for data that we knew we would be using and how we would be using it. With each potential new data request, we asked ourselves and our expert panel, why were these data critical to C3I? How would we use them? And what would be the burden of data collection for the sites who were honestly operating with shoestring budgets, doing really challenging work? As mentioned earlier, we collected data every 6 months on program characteristics, reach and effectiveness. We also created ways to report the aggregate results back to the community, including summary statistics at the all grantee meetings. We created report cards for each site, which highlighted their progress relative to the other sites, with the data of the other sites anonymized for privacy. We heard in our site visits and exit interviews that grantees use these report cards as tools for communicating with their cancer center leadership, giving them an easy, really visual way to highlight the progress they had made, especially relative to other cancer centers, which is important to cancer center leadership. But they also used the reports to potentially ask for additional resources if they felt their program was falling behind. A second outcome from our focus on data collection was an amazing, unique, messy, and beautiful longitudinal data set from the 52 sites across multiple years. The survey data are actually in the process of being harmonized and prepared for transfer to NCI to be made available to future researchers. Finally, our focus on data collection allowed us to report back to NCI in a way that was detailed and that demonstrated that we and they were making data-driven decisions about how to lead C3I for a maximum return on investment. Finally, our fourth principle was to identify and provide tools and resources to meet grantee needs. We always stayed focused on being of service to the grantees as our core mission, and that played out in a number of ways. Very early on in the initiative, we realized that sites were struggling with making changes to and extracting data from their EHRs. With support from NCI, we engaged the services of an EHR consulting firm to advise sites who were using a variety of EHR platforms on how to communicate with their IT teams, how to get access to EHR resources, and how to make simple but high impact changes. We also heard from the tobacco treatment specialists that they often felt isolated and like they were missing out on resources to improve their work. So working with Dr. Jamie Ostroff from Memorial Sloan Kettering, we created a community of practice for cohort 3 TTSs to help them connect to one another into this community and better support program implementation. Finally, as described earlier, we organized seminars and expert speakers at all grantee meetings on particular topics of use to the community. These activities resulted in a number of helpful outcomes, including an EHR scripting guide that IT teams at the cancer centers could use to implement key features needed for tobacco treatment programs. Our focus on frontline staff like TTSs further increased that sense of community and shared resources, as well as the shared learning discussed previously. A number of sites really struggled with turnover among TTSs early in the initiative, and we're hopeful that that feeling of community across and around C3I might help mitigate that specific challenge. Finally, sites told us in exit interviews and other communications that the seminars and external speakers helped them improve program implementation thanks to the extra support. Thinking about long-term impact of this focus on meeting grantee needs, we can see that if our grantees had these needs, others in the broader oncology community working to develop TTPs probably do as well. Through the course of C3I, we have contributed to the development of a field-wide knowledge base of adjacent expertise needed for a successful program, including resources around health equity and equitable delivery of services, EHR use in TTPs, program marketing, training of frontline staff, and other topics. And within C3I, we heard that our provision of these tools and resources produced substantial time savings for program leaders who then didn't have to go out and develop the expertise in all these different topics, allowing them to focus on their program implementation and delivery of improved care. As C3I continued to develop and mature, we in the Coordinating Center, we started looking around at this amazing community developing around us and realized it would be an enormous waste of resources and opportunity if we didn't at least try to maintain the group's momentum and work to transform from these small supplement-funded projects to a broader consortium that would expand and magnify the investment that NCI has made in these programs. So we launched the C3I Consortium, focusing initially on facilitating a number of working groups around priority topics. Our overarching goal was to leverage the C3I network to advance the science on tobacco cessation, implementation science, and healthcare policy. In short, we asked ourselves, what could this unique group of individuals do at this moment in time with the resources available to us? Of course, given our focus on community, our first task was to understand what our community members were most interested in accomplishing beyond their initial funding. So we asked them to send us their most exciting and pressing research questions with a focus on practical questions that could really move the needle on the delivery of tobacco cessation care to cancer patients. And we ended up with questions that fell into these 5 priority topics, including diversity, equity, and inclusion, family and social support systems, implementation science, sustainability, and telehealth. Our approach to the development of the consortium was to focus on creating infrastructure to facilitate cross-network activities, such as supporting the development of proposals for federal funding, publishing manuscripts, and supporting preliminary data analyses. Our previous work on working groups has shown that they are most successful when they have a tangible deliverable to coalesce around. As such, we focused on this key first deliverable for the C3I working groups as a set of position papers to be published in JNCCN in November of 2021. We also created a pilot funding program to try to spur cross-C3I collaborative projects. We solicited applications which needed to be co-led by at least 2 C3I sites, and we gave bonus points for projects with the health equity focus, which they all ended up having. Each potential project was presented at a consortium-wide virtual meeting with 3 expert judges, kind of Shark Tank style, including NCI program directors, Drs. April O and Yvonne Prutzman, who gave each project feedback on their proposals before the formal application process. The 5 projects were all so incredibly smart and full of potential that we ended up funding them all. One measure of consortium success is the extension of the work through ancillary grants leveraging the consortium's resources. And earlier this year, Dr. Ramsey Saloom of the University of Florida received an R01 to investigate the sustainability of tobacco cessation programs at NCI-designated cancer centers. We have been so blown away by the continued engagement of C3I participants in the working groups. Since the launch of these working groups and now consortium, more than 110 participants have continued to engage in the work of C3I, with nearly 40 individuals involved in multiple consortium projects. 45 of the C3I sites are participating from various roles, and it's really important to stress here that funding for some of these participants ended in 2019, and yet they continue to show up. As further evidence of the impact C3I has had on the field of tobacco cessation, as of August 2023, the C3I initiative has resulted in nearly 70 journal articles, many of them engaging multiple sites and/or the Coordinating Center. And you can browse these publications on the C3I website hosted by the University of Wisconsin. Furthermore, the publications have appeared in a wide variety of journals, highlighting the multidisciplinary nature of the teams in this initiative. As the Coordinating Center winds down its operations, a core team at UW, now led by Dr. Danielle McCarthy, serving as the Coordinating Center PI, has created this incredible resource for the oncology tobacco treatment community called the C3I Roadmap for Tobacco Treatment and Cancer Care. This web-based implementation guide provides pragmatic tools, EHR screenshots, and build guides, case studies, and tips to help cancer programs plan, implement, and sustain tobacco screening and treatment programs. The roadmap also highlights health equity considerations and resources. The site is free and open to the public, and you can go to oncologytobaccotreatment.org and register to use the roadmap at any time. And the key takeaway that I'd like to leave you with here is that investments in a robust coordinating center with a focus on community building, continuous learning, initiative evaluation through rigorous data collection, and identifying and meeting the needs of grantees are absolutely essential aspects of coordinating these large research initiatives. Incidentally, they are also strategies that everyone can and should be using to improve every team science project they're on, regardless of size and scope. We have seen in the work of the C3I Coordinating Center how that investment in the CC and the use of evidence-based strategies and guiding principles grounded in research, leads to improved scientific and organizational outcomes, which lead to a deep and lasting impact on human health. And now I'd like to turn it over to my colleague, Dr. Jessica Burris, who will be sharing her experience as a C3I grantee and member of the initiative's expert panel. Dr. Burris.
Thank you, Dr. Rowland. I'm Dr. Burris, and I'm incredibly grateful to present today as part of the Cancer Moonshot webinar series. I'm a faculty member in the Department of Psychology in the College of Arts and Sciences, and the founding director of the Tobacco Treatment Program at the NCI Designated Comprehensive Markey Cancer Center. Next slide. So before I begin, it's important that I acknowledge that this was certainly a team effort. A multidisciplinary group came together with expertise and skills in a broad range of areas to do this work. And from the very beginning, we had the support of the director of Markey, Dr. Mark Evers, who showed his support in numerous ways throughout the work that we've done. Next slide, please. I feel it's important to start with the context of the Markey Cancer Center and our tobacco treatment program. So Markey's catchment area is the entire Commonwealth of Kentucky, all 120 counties. And Kentucky leads the country in both cancer incidence and mortality. Part of the reason why we lead the country in those two outcomes is because we also rank among the top 3 consistently in terms of the prevalence of smoking among adults. Part of the reason why our smoking rates are so high is because Kentucky has a profile of social determinants of health that place our residents at a disadvantage. So both cancer and smoking burden are high in our state, and Markey is here to address those two matters. Next. So prior to C3I, Markey Cancer Center did not have reliable data on smoking or smoking cessation in our patient population. I was able to pull data through the Kentucky Cancer Registry, which is a statewide registry, and focused on patients who were diagnosed and received their initial cancer treatment at Markey. And with that data, we were able to see that about 2/3 were asked about tobacco use and had that recorded in their chart. Next. Unfortunately, that was all the data that were available prior to C3I. There was no systematic screening program in place within our cancer center, no referral system. And while we had 1 to 2 providers who were trained as tobacco treatment specialists, it was hard to know who they were, what clinics they served, and how you could refer a patient in your clinic to someone specifically for tobacco treatment. In addition, there was no broad patient education, and certainly nothing that was developed from the ground up that was tailored to our patient population, and no staff training that was available or robust. Next slide. From the very beginning, there were 3 priorities that we had as a team, 3 things that we valued and wanted to build into our program from day one. First was the population. We wanted to make sure that we reached every adult patient in every single clinic from the very beginning. Having a staggered start was not what we wanted. When we opened up the doors to our tobacco treatment program, we wanted to make sure that we opened doors to everyone. Second was reach. Many of our patients come from far away, 2, 3, 4-hour drives to get to Markey Cancer Center for their cancer care. We wanted to make sure that their travel distance wasn't going to be a barrier for tobacco treatment if they were interested in it. So from the very beginning, the counseling that we offered could be done in clinic, bedside, but also over the phone and through telehealth. And again, this was from the very beginning. Also, we wanted to make sure that education was at the forefront of what we did, but not just for patients. It was important to educate the providers of our cancer care, as well as our frontline staff, who were the first people to greet patients in clinic about the importance of tobacco cessation and make sure they understood the evidence-based tobacco treatments available to them. The third thing that we valued, and that was incredibly important for us and for C3I as a whole, was equity. We needed to make sure that our tobacco treatment program and the services within it were accessible and were without costs, knowing that finances is often a cost to taking advantage of tobacco treatment. For this reason, we chose to partner very closely with the Director of Psych-Oncology Services, Joan Scales at Markey Cancer Center, and embed our tobacco treatment program within that already well-established clinical service. The services within psych-oncology are provided free of cost, and therefore we knew that finances was not going to be a barrier, at least for counseling. The other benefit of partnering with psych-oncology is that the social workers within this unit are fully versed in and able to address social determinants of health. We know that there's a close link between people who have socioeconomic disadvantage or who are racial or ethnic minorities or other minority groups in terms of accessing and receiving tobacco treatment. This was not going to be as much of an issue for us, again, because the people who were trained as tobacco treatment specialists were also versed in social determinants of health. Next slide. We received funding as part of cohort 1 in October 2017, and then we later received an enhancement award. The program that we built was multifaceted. Provider education was certainly one of the main things that we focused on. So we were able to work with the committee that oversees the research seminar series for Markey Cancer Center to make sure that there were protected slots every single year for individuals who are doing research in tobacco control, tobacco cessation, and tobacco policy. We wanted to make sure that all of Markey members were getting information about cutting edge, late breaking, and impactful tobacco treatment and other options. Secondly, we invited experts from across the country to come and visit us at Markey Cancer Center to speak with our oncologists and other care providers, to speak with frontline staff, and to speak with researchers about the work that they do, again, trying to bring tobacco to the forefront of people's minds. Third, our team chose to visit our clinics. We trained and worked with the frontline staff who did the screening. We met with oncologists, we met with nurses, we met with the psych oncology service several times to make sure that everyone was on the same page and that processes that we were developing actually worked in the setting in which we wanted them delivered. The third aspect of education came through the Breathe Tobacco Treatment Specialist Training Program, which is a fully online accredited program that's run by Dr. Audrey Darville in the College of Nursing at UK. Patient care, of course, was number one in our minds, and we refer to our program as the Markey Cares Tobacco Treatment Program, and you can see what that acronym stands for on the right. And then, of course, program evaluation. It needed to be continuous and robust. We extracted data from the electronic health record as well as the state registry. We received data back from TELAS Quit Manager, which is a group that we partnered with in the beginning. And then we also did data audits where we could extract data for a particular clinic and then report that back to the clinic with comparison to the other clinics under the Markey Cancer Center umbrella. Next slide. In terms of the Breathe TTS training program, to date, we've trained 20 Markey providers as tobacco treatment specialists, and we've also trained individuals who provide oncology care at the affiliate networks, which are located outside of Lexington, but in the state of Kentucky. We also have commitment from Dr. Mark Evers, the director of Markey Cancer Center, such that all full-time staff who are hired into psych oncology who want to be trained as tobacco treatment specialists can do so without paying the registration fee. That should be covered by the Cancer Center. Next slide. The patient education materials that we developed were done through an iterative process. We wanted to make sure that the images that we chose to include reflected the patients that we serve and had a positive image attached to them. We also wanted to make sure that we address some of the myths that go along with quitting smoking and the relationship between cigarette smoking, other tobacco use, and cancer outcomes. And so we partnered with a health literacy specialist within UK Healthcare to make sure that our language was appropriate for the patient population that we serve, and also to make sure that we were addressing things in a respectful way. Next slide. Our program has multiple elements tied to it. When we first started, Markey Cancer Center had 5 different EHRs that were in use, but we figured it out and we built something that worked. And then about 3 years into our program, we got rid of all of those electronic health records, and UK Healthcare adopted Epic as the sole EHR in use. That meant that we had to completely redesign our screening, relaunch it, and retrain everyone, but we got that done. In the beginning, we partnered with an outside vendor, TELAS, to do screening and provide motivational messages and to have a referral back to us and the TTSs on site. Eventually, though, we decided that the best approach for us in terms of sustainability was to partner with Quit Now Kentucky, which is our state quit line. Quinal, Kentucky had long wanted to partner with UK Healthcare for a closed loop e-referral system. And I'm happy to say that Markey was able to finally get this in place. And this e-referral system is now available throughout the entirety of UK Healthcare Enterprise. And that was led by Markey. We're able still to search our EHRs and get data back from the quit line. And of course, the goal is to support smoking cessation and other tobacco cessation among our patients. Next slide. So this is where we are today. You can see pre-C3I, we didn't have much information about tobacco use or quitting among our patients. And now we're able to track these things prospectively. Currently, we're focusing on what is circled in the middle. Next slide. So one thing that we found is that there's a pretty low rate of acceptance of the offer for tobacco cessation assistance. Usually only around 20% of patients say yes, they would like help with quitting. And what we have in our screening are discrete response options for the reasons why they decline our help. The number one reason is because our patients are not ready to quit. And that's why we ask them repeatedly over time, because we know that motivation to quit can change as things change in their lives. But the number two reason why people decline our help is because they want to quit on their own. And so a PhD student in my research lab decided to focus on this issue for her dissertation and conducted a mixed methods longitudinal study with cancer patients who smoked and who said that they declined help because they wanted to quit on their own. In some of the qualitative data, we found 4 themes that explain this. The first is self-reliance, basically that patients are saying that they want to be able to do it by themselves because they do so many other things by themselves, and that gives a sense of pride. Secondly, there's the ideal of willpower. The last 2 ideals really center around norms, remembering times that they've been able to quit on their own in the past, and then also the ideal that others have been able to quit without any treatment, and so maybe they can do it too. Next slide. So quality improvement is a continual effort, and so we're trying to figure out what messaging we can provide to address this kind of cultural and personality factors that decrease the likelihood that patients accept our help, and we'll be working with retraining our staff to see if we can make our offers align more with the culture of the patients that we serve to try and get the uptake higher within Markey Cancer Center. Next slide. So I'm happy to say that our tobacco treatment program is still going strong, and we're committed to continuing to work with the frontline staff and our providers. And have actually decided that we need to retrain some clinics in our screening program to make sure that things stay and that best practices continue. And we'll be doing that work later this year. Also, with the partnership with the Quit Line, our program has extended beyond Markey throughout the entirety of UK Healthcare Enterprise. And just a few months ago, I learned that the Lexington Clinic, which is an independent healthcare system in Lexington, which is where Markey is located, learned about our program and they want to adopt it for their setting. They're going to use the same screening questions and referral processes that we have, and they're looking to partner with the state Quit Line as well. So again, this will further extend tobacco treatment that is evidence-based to cancer patients, not just in Lexington, but throughout the state of Kentucky. Next slide. Thank you.
Thank you, Dr. Burris. To wrap up here, we wanted to leave you with these key takeaway messages. Health system interventions are hard, but they have some common pitfalls that can be addressed through common tools like EHR resources. A strong coordinating center can multiply and amplify the efforts of consortium participants. Infrastructural support and facilitation focused on common scientific interests can motivate participation well beyond funding. Focusing coordinating center resources on equity can lead to improved population-level outcomes and organizational outcomes in consortium participation. And finally, core population health needs like tobacco cessation cannot be simply encouraged, but must become funded mandates. Just wanted to acknowledge the contributions of our NCI colleagues who are critical to the success of C3I, including Drs. Michelle Block, Bob Croyle, Stephanie Land, Glenn Morgan, and Stacey Vander. Our C3I funded sites who participated and showed up in ways that were amazed and astonished us and continue to do so. Our C3I expert panel provided incredible scientific guidance, especially as we developed our data collection strategy, and our three C3I consortium chairs who are keeping the collaboration going. So thank you for your attention, and please feel free to contact any of us with further questions. All right. I'm going to move into the Q&A.
Yes.
Great. All right. Got a couple here in the Q&A. So maybe this one maybe goes to Mike. Is there a sense of whether an awareness of the importance of quitting for all cancer patients improved after these programs?
Great question. We didn't evaluate that question specifically across the funded sites, but without a question, there was a sea change in the funded sites in terms of how tobacco was addressed. And it's an ongoing process, but clearly it's recognized that addressing tobacco use is important. What's been particularly helpful is the new data that says that if you quit smoking, you're more likely to survive your cancer and you're less likely to have side effects from your cancer treatment. That's data that's not commonly known, but it has a powerful impact, particularly on providers, but also to motivate patients.
Thank you, Dr. Fiore. The next question, where can one find the resources that you mentioned? Is the list of experts available for others beyond COC? If there's anybody here from the Coordinating Center who can maybe put the link to the Wisconsin C3I site, there is contact information there, and you can reach out to the Coordinating Center for those additional resources. Next, Dr. Burris, you mentioned an iterative process for developing educational materials. Did you get feedback from patients, and did you assess patient understanding of the materials?
Yes, we did. I failed to mention that. That was certainly an eye-opening experience for me. We have a patient advisory group within Markey Cancer Center. And so we had drafted our booklet, which is about 20 pages total, and we presented it to the group. And they really didn't like it. They gave a lot of really critical feedback that was hard to hear, but ultimately very constructive and very helpful. And we were able to revise it and work with our team and work with the research communications office that we have at Markey Cancer Center to make it stronger, better, to make it fit the population more, and to make it more acceptable, if you will. So we took that revision back to the PAG, and then they loved it. And so we felt confident then we were able to distribute it and roll it out. It is something that we look at to make sure that the information stays current and accurate, and are thinking about potentially making some revisions, again, as we're learning more about the idea of wanting to quit on one's own.
Excellent. Thank you. Next question is, any thoughts about how we can translate what we learned from C3I to other health behaviors or cancer prevention efforts? Dr. Burris, would you like to start that, or any thoughts?
That's a really good question. I think the structures, the infrastructure in place and built by the Coordinating Center is certainly translatable to a lot of different topics. I think one behavior that would make sense is any sort of substance abuse that is harmful or heavy misuse. That seems like an easier translation, but to more cancer prevention, that might be a heavier lift.
Dr. Fiore, did you want to weigh in? No.
No, I thought that was great, Dr. Burris. Why don't we leave it at that?
Excellent. I would just add, the one of the things that we heard from our funded sites was across initiatives, they were struggling with the EHR use. Right. So having those EHR tools is really helpful, and is one thing that you can use to gather the data and to evaluate the initiatives. I'm going to read this one from Dr. Klein. Just wanted to congratulate the C3I team on a terrific trajectory of progress in the C3I initiative. We here at NCI think of it as one of our success stories and a model for other similar initiatives. So thank you, Dr. Klein. We've got the link was put in the chat for the roadmap, so thank you for that. I'm curious if there was any interest in understanding of how funded sites continue to sustain programs financially after funding ended. Great question. So we did survey the sites as they ended their funding and asked them for their sustainability plan, because that was something that was written by NCI into the RFAs, that they were required to sustain their programs for, it was either 2 or 3 years after the NCI funding ended. So we do have data on how they plan to do that. And I think Dr. Saloom's R01 will be expanding that work to better understand that financial sustainability.
I can just add to that specifically at Markey. That was part of the reason why we pivoted from working with an outside vendor to partnering with the state quit line. When the funding started to go away, we had concern about the cost of continuing to work with that particular vendor. And the state was really eager to partner with us and to cost share some of the startup of putting the referral system in place. And I know that other eye cancer centers made similar choices, moving from working with an external vendor to working closer with state or county health departments.
And I'd just like to add, you can't overemphasize the power of Moonshot getting involved in this. The fact that they designated this as a core program and funded it meant that all cancer centers had an additional matrix upon which to be judged how much they were doing to help their cancer patients who smoke to quit. And the new emphasis on the new Moonshot initiative to cut cancer deaths in half is an additional motivator. There is now a HHS-wide initiative around smoking cessation. So again, Moonshot speaking about this and funding it fundamentally motivates cancer centers and cancer treatment facilities in the community.
All right. The last question we have here is, do you have any NRT education videos, and what other languages do you offer your materials in? Dr. Fiore, do you have that information?
Well, we for sure have information on NRT. As Dr. Rowland mentioned, you could reach out to any of us for additional information. I would be happy to send some information. Our materials depended upon the site. That was one of the great things about not being prescriptive about what the 52 sites do. So sites that were in locations with high Hispanic populations really emphasize having bilingual materials, and we have those available.
Well, with that, I think we're at the top of the hour, and that was a great Q&A session. Thank you, Drs. Rowland, Burris, and Fiore. I really appreciate it. The Cancer Moonshot Seminar Series will resume in November, so stay tuned for our next set of speakers. Please publicize these. These are great resources. And again, this is recorded and will be available in a few weeks. So if someone missed this, you can send the link to that as well. Thank you, everyone.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4CANCER.